Welcome everyone, and we are excited today to have two excellent guest speakers, Dr. Melissa Mugambi and Dr. Karen Ryan, who are going to talk to us with Dr. Mugambi, starting with talking to us about the design of community-based HIV service delivery models using the stated preferred methods. But before we dive into that, I wanted to remind you about the CFAR Seminar, which is a forum for presenting and discussing the state-of-the-art research findings in HIV, pathogenesis, virology, care, and treatment, and provides an opportunity for ongoing enhanced communication and multidisciplinary collaboration among HIV/AIDS researchers across our 5 CFAR-affiliated institutions and their organization. So we'll have 2 sessions, which one first I will have Dr. Mugambi, and then second one will have Dr. Ryan present. So I'm excited today to introduce my colleague, Dr. Melissa Mugambi, who is an assistant professor here in the Department of Global Health at the University of Washington. Prior to her appointment here at the University of Washington, she served as a program officer and fellow at Bill Melinda Gates Foundation in the diagnostics team. Dr. Mugambi received her medical training from the Northwestern University School of Medicine, and her doctoral degree in health sciences, services, research and policy from the Case Western Reserve University, where we spent at least 2 years overlapping each other. Her current work and practice interests focus on designing service delivery models to optimize access to health technologies in antenatal care programs, as well as fostering local product content development efforts through entrepreneurship and training. She's currently the PI of the National Institute of Mental Health Career Development Award, which is aiming to design and evaluate strategies to implement HIV prevention interventions for pregnant women in a community pharmacy setting. So with that, I will hand over the audience to Dr. Mugambi. Thank you so much for accepting to come and talk to us.
Yes, thanks, Dr. Mugwanya, for the invitation. I'm going to go ahead and share my screen. And hopefully you can all see that.
Yes.
Okay. So as Ken mentioned, I'll be talking about the design of community-based HIV service delivery models using stated preference methods. I believe I have about 20 minutes or so. So I'll be a bit brief so that we can give Dr. Ryan some time to speak as well. Okay, and Ken gave a helpful overview of my background. And so briefly here, my interests really are in service delivery, innovation, and global health. And my training is in medicine and health services research. And my research interests really are to design novel community-based models to deliver HIV prevention services and apply stated preference methods such as discrete choice experiments to service design, and also apply implementation science methods such as the design and tailoring of implementation strategies to service design. And the agenda for today, this like a brief talk, is really to just provide a brief overview of what discrete choice experiments are, and then discuss my initial foray into discrete choice experiments, conducting a pilot DCE. And our goal as part of this project is really to understand client preferences for ART delivery in KwaZulu-Natal, South Africa. And then briefly talk, if time allows, about some of the other ongoing DCE projects in which our teams are working on. So this is one of the reasons that I'm looking at service design, is really to understand what uses value. It is an important aspect of service design. And the reason being is we want to create value for users when they use services. We want to improve the uptake of services, and we want to improve the impact of services. And we can understand what users value by evaluating their preferences or their choices. And there are various methods that can be used to evaluate preferences. So there are stated preference methods and revealed preference methods. Stated preference methods typically ask questions like, what will you do? So it's more of a question of like, what will you choose? While revealed preferences is based on actual behavior. So it's more, what did you do? So as an example of a revealed preference method, we can use pre-post design, so using surveys and observed behavior to actually understand what choices people are making in real time. For stated preference methods, there are various methods that exist. For example, ranking exercises or discrete choice experiments. These consider really opportunity, cost, and choice. So they capture the idea that if something is of value, then a user is willing to give up something for it. And then there are other methods where no choices are made, essentially, so like self-assessment surveys or using visual and analog scales. So for the purpose of this presentation, we'll largely be focusing on discrete choice experiments. So discrete choice experiments are based on the idea that people value the characteristics that make up a service. There's actually a nice video on YouTube by the Health Economics Research Unit at the University of Aberdeen that discusses discrete choice experiments, and they use this quote. And what you see here is what you'd call a series of two services described by different characteristics or attributes. And so in this example, this in fact captures a decision that I had to make the other day when deciding which primary care provider to see. I had the choice of going to the clinic, let's call that service A. And in this particular case, the soonest I could schedule an appointment was within 10 days. I would see a female provider and I'd have to travel about 20 minutes to my appointment, to the clinic. Alternatively, I could choose service B and I could schedule my appointment within 2 days, see a male provider, and it would take me roughly 5 minutes or less to get to the clinic. And in the end, I opted for service A because seeing a female provider was more important to me. And so this is just goes to show that when given a choice, we select a service based on characteristics that are more important to us. So when people choose services, they make trade-offs among attributes. And so what happens is that we can quantify the relative importance of the attributes. And this just shows a list of potential questions or services that people might have to select from. So in discrete choice experiment services, we present people with a series of questions that ask them to choose among alternatives. So in this case, this is alternative services, and a certain benefit or utility is gained from choosing a service. And then we can quantify the extent that each attribute level contributes to the overall utility gained from the service. And in this example just shows that service A is picked several times, mainly because of attributes which are of importance to the person taking the survey. So what we can do with this data, we can analyze and use the choice data generated from DCE surveys to design service delivery models. And how exactly do discrete choice experiments aid design? So firstly, one thing that we can do, we can use discrete choice experiments, and I'll explain in a pilot study that we conducted, to help us identify the preferred service delivery model. We can also use them to identify key components to integrate into the model. So basically, which are the key features of a service that we should incorporate into that service. And so, for example, if an attribute is highly valued, we can explore how to incorporate it. At the same time, we can also address potential limitations if we're unable to implement it. Similarly, if an attribute is not valued, we can deprioritize features that might be less likely to influence one's decision to use a service. We can also identify which combination of service components are likely to improve uptake. And finally, we can also engage various stakeholders in the design of a service by having them weigh in at different stages of DC development and the DC itself. So as an example, during a pilot DC, we engaged art clients in KwaZulu-Natal, South Africa, to understand their preference for art delivery. Specifically, this work helped us to identify the preferred service delivery model, and we were able to engage both art clients and experts to inform the survey. And I'll briefly talk about this work now. So, as you may be aware, HIV still affects over 37 million people globally with a disproportionate burden of disease in Eastern and Southern Africa. As of 2020, there were 20.7 million people living with HIV. The adult HIV prevalence stood at 6.7%. There were 730,000 new HIV infections and 300,000 AIDS-related deaths, and 73% of adults were in antiretroviral treatment. Specifically in South Africa, of the 7.5 million people with HIV, 70% are on ART and only 64% are virally suppressed. And in the study area in which we were focusing on, the KwaZulu-Natal, the population at HIV prevalence stands at 36%. So clinic barriers ultimately affect one's ability to collect medication and remain virally suppressed. And some examples of clinic barriers include long wait times, long travel distances, time constraints, and negative treatment from staff, which means that medication is not collected as directed, and there is a failure to suppress viral load. And the idea behind the study is that alternative community-based delivery models might be more convenient and flexible and overcome clinic barriers to care, and therefore improve viral suppression. So in this particular pilot DC, we followed key steps to implement the pilot DC and ultimately understand client preferences for art delivery services. We consulted the literature and experts to develop attributes and levels, so the characteristics of the delivery service. We designed a survey, so we developed choice questions, as I'd shown earlier, so a list of alternative service options for participants to choose. And then we conducted the survey among 180 people living with HIV. And actually these individuals were enrolling in a trial to evaluate a home-based delivery model. And finally, we analyzed the choice data resulting from the survey to estimate the relative importance of each attribute and the relative contribution of each level to utility gained from a service option. So we selected and defined 3 attributes that were most likely to influence the decision to participate in a delivery service. This just shows our initial list of attributes that we had obtained from the literature. And through discussions and ranking exercises with the team, which included clinicians and researchers who have worked with and treated people living with HIV in the region, we identified 3 attributes, which were delivery fee, delivery timing, and delivery location to include in the survey. So we described delivery fee and location using 3 levels and delivery timing using 1 level. So delivery fee is described as how much the client is willing to pay for the delivery service every 3 months. And the levels are 30, 60, or 90 South African Rand. Delivery timing was when the client prefers to have art delivered, and this was during and after work hours. And delivery location was where the client would like to have art delivered, and the options were the client's home, the client's workplace, or the community center. And what we did was we generated 5 survey designs based on these attributes and levels, each with 12 choice sets, so 12 questions using SAS. I'll briefly walk you through how we did this. So the goal of creating the experimental design is to systematically vary attributes levels so that we can determine the effect of these levels and what participants choose. So the first step involved generating a set of 18 service options. So because we have three three-level attributes and 1 2-level attributes, there are 3 by 2 by 3 or 18 possible combinations of these attributes and levels. So one service option, so this is an example of 2 service options. So one service option, for example, would be a service in which the delivery fee is 30 Rand. The art is delivered after work hours, and the delivery location is the community center. We then asked SAS to take these 18 service options, alternatives, and generate survey designs with a series of 12 choice questions. So this would be an example of one survey design and your 12 choice questions. And then this is the choice question over here, or choice set. And so essentially what would be shown to participants, there were 5 versions of the survey generated. They would see a list of questions and they could pick either service A, service B, or neither, being that they wouldn't be interested in either service A or service B. This is also known as opting out. Of note, I won't go into too much detail here given the timing. I don't think I have a lot of time here, but in addition, there are certain things that go into generating the survey to ensure that we have a really good survey design. One thing that we want to do, like when we program this in SAS, we want to ensure that it's an efficient design. And simply an efficient design is we want to minimize the variances of the parameter estimates. So given an assumed parameter vector beta. And also we want to make sure that no alternatives dominate. So basically no alternative service really appears better than another one, so that an individual doesn't really trade off or is forced to make those choices. And we also want to make sure there are no duplicate alternatives, want to make sure that these level balance so that we don't have each attribute appearing. So we want to have each attribute level appearing the same number of times. And another characteristic that we want to have is orthogonality. So basically we want the occurrence of one attribute not to depend on the level of another attribute. So there are different things that go into the design. So ultimately we had 5 survey designs that were presented to participants, and each participant saw one design, one of the 5. So we conducted the survey among people living with HIV who are enrolling in a trial to evaluate home-based delivery of art versus clinic-based art. The trial was conducted from October 2019 to January 2020. Participants were largely enrolled from community-based programs and HIV clinics and were 18 years or older. Trained research assistants administered the survey in person using tablets, and they used cards to show images of the different options. And in addition to the preference survey or Dces survey, the survey asked participants about their demographics, HIV, and clinical history. And we conducted several analyses to better understand participant characteristics and choices using data. So including a descriptive summary of demographic and clinical characteristics, as well as of choice statistics. We run a conditional logit model as the base model, and then a mixed logit model to analyze participant choices and estimate preference weights. So the choice, which is the outcome, was modeled as the dependent variable and dummy coded, and the attribute levels were independent variables and effects coded. And just to point out the key difference, so between conditional and mixed logit models, unlike conditional logit models, mixed logit models assume individuals do not have the same preferences and assume errors across choice tasks might be correlated. So they're often the model of choice for discrete choice experiments. So just briefly, the majority of participants were female between the ages of 25 and 44 and were single. The majority of participants were unemployed, had completed at least a secondary level education, so high school, and were currently on antiretroviral therapy. And then across all choice sets, 87% of participants preferred some sort of delivery service. So basically, they preferred either service A, service B, if we looked at across all the choice questions. And then 1% or 2 of the 180 participants always opted out. So they always selected neither service across the entire survey. And then 51% or 92 of the 180 participants always selected a service option. So they did not opt out at all. And so these are our findings from our initial analysis of the choice data using a conditional logic model and Stata. And just briefly, what this shows highlighted in yellow is the coefficients or the beta coefficients. And from this, we know that delivery fee and delivery location are statistically significant. That is, they are more likely to influence one's decision versus delivery timing. We also see that the opt-out option is negative and significant. And I'm going to talk more about what the implication of these findings are. We did go ahead and run the mixed logit model. And so here, this shows the mean preference estimates. And once again, it also consistent with the conditional logit model suggests that all attributes except delivery timing affected participant choices. So this is another way of looking at the data. This figure shows the preference weights by attribute and attribute level. And it shows delivery fee was the most important attribute, followed by location and then delivery timing. And really, we know this because we simply take the difference between the highest and lowest utility for each attribute, and attributes with larger differences are more important. So you can see this change in utility gained is much larger than this one here. So this is seen as the more important attribute. And then here you can see in this figure that there's little utility gained in moving from delivery during work hours to delivery after work hours. And again, this attribute is not significant. So higher preference weights suggest greater preference for the select attribute level by participants on average. And we see that delivery at home on average was preferred to delivery at work, and delivery at the community center was also preferred on average to the delivery at the work location. And as expected, we also see that lower delivery fees were preferred. Lower delivery fees here were preferred on average over higher delivery fees, 60 and 90 Rand. It's important to point out here that we have a negative opt-out and it's significant. So on average, people want to opt in for some sort of delivery service. Essentially, they see this, that the service has a potential to make them better off. They see it as an improvement over the status quo. And here we're assuming that participants interpreted the status quo as picking art from a clinic, so the standard of care. And so our findings show that essentially this is a good concept, the idea of home-based delivery or alternative delivery options. We just need to work on the design. So just in summary, study participants strongly preferred low-cost services and home-based delivery compared to a community center or workplace. And a negative opt-out suggests some sort of interest in the delivery service. And though there might be a few people who are actually interested in clinic-based delivery, what I haven't shown here is the standard deviations, which represent the heterogeneity and preferences. And so for the negative opt-out, there was quite a bit of heterogeneity, which is significant, which shows that there might be a few people who are actually interested in clinic-based delivery. And this makes sense. So there are prior preference studies in other settings, such as Kenya and Zimbabwe, that highlight concerns about the potential stigma and failure to receive comprehensive care in a home-based model. So people might still be interested in the clinic-based model. But however, with growing interest in e-commerce channels, there might also be a shift in the acceptance of home-based models in the context of HIV treatment. And then as part of future work, maybe rather than have an opt-out option, which sometimes can be seen as ambiguous, we could possibly have a clinic option. And so people actually know what it means when they're opting out from the particular service. And what does this mean for optimal program design? I think going forward, I think it's important to understand the context and for whom home-based services make sense, kind of falling on in that idea of heterogeneity and preferences. It also means that diverse options for delivery are important, and we can consider an additional DC to help flesh out key components of home-based services. And I think I am short on time here. Ken, how are you doing for time?
Yes, we are short on time, so we can.
Okay, so I'll wrap up. This was just to show the different DCs that are in the pipeline, and I'm happy to take questions offline. In summary, I'd just like to highlight some of the pros and cons to using DCs to design community-based HIV service delivery models. Some of the disadvantages are that people don't always do what they say they will do. There's hypothetical bias. Sometimes it's difficult to design the surveys and analyze the data. The methods can be challenging. And it's not always easy to include all attributes because that results in longer surveys that pose issues such as cognitive fatigue. The advantages are we can evaluate new services that don't exist yet. We can engage diverse stakeholders, find out what is desirable to them. And at least this is one of the better ways of simulating choice behavior. And with that, I'd like to acknowledge these individuals, and I'm happy to take any questions or hand it over to Dr. Ryan. Thank you.
Thank you so much, Melissa, for this excellent presentation. We can take one or two questions, and then we can either write them out or we can have those questions at the end of Dr. Ryan's presentation. So open for two questions to Dr. Mugambi.
So I see a question from Kai Tram about the use of latent class analyses. I think that's an excellent question. It's actually, I have not used latent class analyses, and I think that will be important, especially considering there was some heterogeneity observed, and heterogeneity can be observable or unobservable. And we did try to stratify the analysis by gender and employment to see if there were any differences between those who are employed or not employed, or male or female. And we didn't, these models were actually not statistically significant for each other. So these observable characteristics did not explain the heterogeneity, but we can, at least in future work, hoping to take that on and explore how to use latent class analyses to explore, to understand unobservable characteristics that explain heterogeneity.
Excellent, thank you. Really exciting talk from the audience in the chat about that. If there is no other question, we can move on. One more call. Do we have another question, Penny?
Yeah, I see one from Chase Cannon.
Okay.
He says, I'm very interested to do something similar here domestically for PrEP services, understanding fully well the need for using this convenient sample. Do you think your opt-out findings would be different if you conducted the study among a general population of patients rather than those who are already agreeing to enroll in a home-based delivery study, which is a really excellent question. I do think this would be interesting to explore because, you know, maybe there could be some bias in that they were already aware of the home-based services and what have you. So in the general population, maybe you would have seen more people who opted out. I think in this case, it was roughly 13% who opted out. So it's possible that that proportion of people opting out would be larger in the general population. Really good question. Thank you.
Excellent. This is the last question. Connie,
there is another question?
Yeah, from Connie Keller.
I see a one from, is this in the chat?
No, it's a hand up, yeah.
Okay.
Connie, are you able to ask your question? Okay, maybe not. Okay, thank you.
There was one from Nancy, which I'll just answer briefly about validation, which is a very good point. I guess it speaks to the issue of hypothetical bias, in that people don't always do what they say they will do. I think there is a push, actually, even internally from choice faculty here, to really understand whether to validate. So basically to run a discrete choice experiment and then roll out, let's say, a service, and see if people actually select services that they selected in the survey. That is definitely a helpful way of just kind of really understanding whether DCE really reflected participant choices. But in the absence of that, there are methods that can be used to really validate choices when we're not able to introduce the actual service that people use to address this issue of hypothetical bias.
Okay, great. Thank you so much, Dr.